Anyways, I'm Gary Ferenchick. I'm a primary care doc from Michigan State. I'm going to be with you today and tomorrow morning, and then sometime tomorrow I'm going to be heading back. So the first topic we're going to be talking about in the next half hour or so is going to be allergy. And the first area we're going to start with is rhinosinusitis. So rhinosinusitis, of course, is inflammation of the nasal passages, the sinuses and the like, leading to all the symptoms that you're well aware of. But what separates an allergic rhinosinusitis from a non-allergic rhinosinusitis is really the presence of sneezing and itching that is mediated by the IgE response to inhaled allergens is put up there. Interesting that you're going to find also, when we go briefly through some of the pharmacotherapy for rhinosinusitis, it overlaps fairly substantially with some of the pharmacotherapy that you're used to thinking about for asthma as well. There is a differential diagnosis, of course. I'm not going to go through each one of these, but a couple I wanted to point out. There are a certain number of medications, such as alpha blockers, that we commonly use for BPH that can be associated with watery rhinorrhea, mostly in men who are using it for that condition. So don't be fooled. There are certain medications that can be associated with this. It's generally not inflammatory. In addition, if you get a question on the test where you have unilateral drainage, don't be fooled also. This is not consistent with an allergic or non-allergic rhinosinusitis, commonly a foreign body and or a tumor. So in 2017, the Allergy Society basically came out with new treatment guidelines that really talked about allergen avoidance, where possible, of course, pharmacotherapy, and then allergy immunotherapy for more refractory cases. And you can see what I've highlighted there on this slide here is that inhaled or intranasal corticosteroids are the number one choice for managing symptoms because they deal with all of the nasal symptoms that patients come in with. There are other therapies listed on this slide here that are useful in inhaled corticosteroid failures that target specific symptoms, of the nose. For example, you've got your antihistamine sprays listed up there that are really useful for itching and perhaps sneezing as well, less useful for congestion. So what is the patient's prominent symptom? If it's sneezing and itching, these would be useful. On the other hand, if they have more congestion than is handled, for example, by the inhaled or the intranasal corticosteroids, leukotriene inhibitors are quite good for that as well, such as montelukast. So you can add on therapy depending on what the patient's symptom complex looks like. And there's also some other basic, what I might refer to as niche therapies. Intranasal cromolyn works quite well. It's really limited by the number of times you have to take it. It's basically 4 times a day dosing. The nice thing about cromolyn is it's fairly fast acting. So if you have a patient who always goes to grandma's house and always gets allergic response because the cat's always there, this is useful to use an hour or so before going, can minimize those symptoms and the like, generally not considered useful for long-term maintenance just because of the frequency that you need to take it. Ipratropium can be used. Atrovent basically is a trade name for watery rhinorrhea. You got intranasal decongestants, which are wonderful, but of course you get the rebound effect, so they're quite useful for a day or so, after which you basically they lose their effectiveness. And sometimes you need to go to short courses of oral corticosteroids to manage patient symptoms. Allergic eye disease, relatively easy to diagnose. You've got the signs of inflammation, and the itching can be seasonal or perennial. And again, the treatment is relatively similar to the types of classes of medications that we might be using, for example, in the second line for allergic rhinosinusitis, such as olopatadine, which is a mast cell stabilizer. You can use that for both eye as well as Patanol is the trade name for that for the nasal symptoms as well. Now, in terms of allergy testing, there's several reasons to do this. Number one is to rule out or rule in allergies as a cause of the patient's symptoms, to identify a specific antigen to target, and ultimately to target treatment. Now, skin testing, think about that as a bioassay essentially, is preferred over in vitro testing for a lot of reasons. First of all, it's more rapid. Second of all, it's more sensitive. It's highly sensitive compared to the in vitro testing. And interestingly, I wouldn't have intuited this is actually less expensive as well. And there are some contraindications. Probably the biggest one up there is if somebody had a history of anaphylaxis, you don't want to obviously go ahead and expose them to that potential antigen that might produce that specific outcome. The IgE serum tests are less sensitive, as I mentioned, about 70% as sensitive as the skin testing, but clearly have a role in identifying a specific antibody, IgE antibody, basically. However, the use of that antibody, of course, has to be interpreted in light of the patient's clinical symptoms. So it's a little less specific when it comes to this idea of, is this specific IgE causing this specific clinical complex, basically. What about allergen immunotherapy? This is the only therapy that alters the abnormal immune response that's underlying the allergic disease in a semi-permanent manner. Everything else that we give is really basically treating the symptoms but not underlying the basic pathophysiology. This is essentially the gradual administration of increasing amounts of allergen to ultimately get the patient sensitized to it. And you might consider using this for patients who have unacceptable symptoms after pharmacological failure. You've gone through all of your basically armamentarium and they're still symptomatic. They can't avoid allergens for whatever reason. And number 3, you've identified a specific IgE antibody associated with a patient's specific symptom complex. It's effective for asthma. It's effective for allergic rhinitis. That can be pretty severe, and for hymenopterous stings as well. And the only major contraindication is uncontrolled asthma. The big issue with allergen immunotherapy is that people have to have fire in their belly, right? They don't even start to see a response for 1 year after these weekly injections, and the full response doesn't accrue after 5 years. So, if you're considering sending patients off to that type of a process, they need to know what they're in for just with regards to commitment. All right, occasionally, I've only got one question embedded in this session. The other sessions I'm doing, I have other questions embedded. But let's just go over this. So we're moving on to a new part of the allergy talk. 35-year-old woman has seasonal allergies and asthma since childhood. She's currently using an albuterol inhaler, so a SABA, short-acting beta agonist, to relieve her symptoms of wheezing about twice a day, and wakes up at night with cough and wheezing at least once a week. She does not smoke and has no pets. Her home environment is clean and without excess dust or moisture. Today's exam is normal. Which therapy recommendation would be the most appropriate at this point? You want to increase her albuterol inhaler to every 6 hours, regardless of symptoms. Add a LABA, long-acting beta agonist, such as salmeterol. Add an oral antihistamine, such as loratadine. Add inhaled corticosteroids or an anticholinergic inhaler. Anybody want to hazard a guess on that? All right. How many people chose D? All right. So that is it. So basically, this patient is having symptoms, and we're going to dissect this coming up in the subsequent slides coming up. They're having symptoms of uncontrolled asthma and is not on a controller medication. The controller medications I'll talk about in a minute, but essentially are inhaled corticosteroids going into the lungs, of course, and not into the nose. So that's the big thing that's coming up here. So what exactly is asthma, of course? It's a chronic inflammatory condition of the airway leading to episodic airflow obstruction that is at least partially reversible. So those are kind of the key features. So you've got evidence of airflow obstruction that is at least partially reversible. So what is some of the evidence of airflow obstruction? You have symptoms, of course. The patient in the scenario had a nocturnal cough. I think she had some recurrent wheezing. I don't know if she specifically mentioned chest tightness or dyspnea. Those would be the signs that you have basically airflow obstruction. And in order to identify reversibility, of course, you do either peak expiratory flow or a FEV1, pre-post bronchodilator. And what you're looking for, of course, is reversibility. Is there a difference in the peak expiratory flow from baseline to, several minutes after getting the inhaled bronchodilator? And if it's 10 to 12% or greater, that is evidence of reversibility. Now, a couple of points up here also. I like to throw into some of my talks these don't be fooled elements. So wheezing is neither sufficient nor necessary to make a diagnosis of asthma. Remember, you can have asthma and not wheeze. All of us who take care of patients understand the idea of cough variant asthma. It's the only symptom is cough, but they have asthma as a result of it. And secondarily, you can wheeze for non-inflammatory conditions. Think heart failure. You get edema in the airways, and you're hearing a wheeze, not necessarily crackles at a certain stage in time. That can also be misinterpreted, if you will, as an asthmatic condition. So you need to have some of these other conditions, essentially, or these other features, essentially, to make that diagnosis. So what are the components of asthma care? We have assessment and monitoring. So what is assessment? So I got these tables coming up that I'm sure you've seen at some point in your training, talking about how do we define what category a specific patient's in. For assessment, you're looking at a patient who is not currently on a controller medication. Think inhaled corticosteroids. Where are they at in the degree of severity? You're monitoring for control. And that's after a patient has been placed on a controller therapy. You're going to be looking at the stages of control as well. So they're basically, they overlap substantially, and the tables look substantially the same, but you're looking at them from a slightly different lens. In addition, you got the medications, which medications to use under what circumstances, and elements of patient education. And this is basically in terms of the classification of the severity and how the control is rated, you can see the categories listed up there. And I'm going to basically show this, the two tables coming up, which makes this much more obvious. All right, so this is, I think I might have the tables for patients younger than 12 in the appendix. By the way, I got a lot of stuff in the appendix as well. So the appendix, there might be some stuff in there, an asthma action plan and things like that in there. Inhaled corticosteroids, what's a low dose, medium dose, and high dose. So not enough time to go over that during the talk, but it's in there for your review. So here we got a classification of asthma severity in an adult-ish, age over 12. And what I really wanted to point out here is that if you look at the category or the line called symptoms, nighttime awakenings, and SABA use. So if you have symptoms 2 or fewer times per week, if you're using your SABA, and this is a nice thing to think about when you're managing patients, how often are you using your short-acting beta agonists? If it's 2 times per week or fewer, they're in that intermittent category. Once that rule of 2, I look at it, starts to get into 3 and 4 in terms of nighttime awakening, symptoms, and SABA use, you're moving into more severe, persistent categories of asthma. And the easiest thing to do is just look at the peak expiratory flow. Okay, so if they're using their SABA, for example, in this paradigm, more than twice per week, and their peak expiratory flow is like 70%, they're going to be in the moderate, persistent area right there. If it's less than basically 60%, they're going to be in the severe category and the mild category. So if it's greater than 80%. So combining how frequently are they having symptoms and or using their SABA and their peak expiratory flow can get you pretty easily into one of the categories. Again, in patients not on a controller medication. So you're classifying the severity before putting them on the controller medication. Now, this table looks remarkably similar. You've put them on the inhaled corticosteroid. Now you're basically asking the same questions. How often are you having symptoms, in terms of weekly symptoms? How often are you using your SABA? How often are you waking up at night? And using the same parameter when it comes to your FEV1. You got basically greater than 80%, 60 to 80%, or less than 60%. So if you can remember those 2 features here, pretty easily can get you into the ballpark of whether or not you need to step up therapy or whether or not the patient is actually doing well with regards to your management. Now, in terms of long-term controller medications, you can see there's basically a whole list of them on here. But again, much like we talked about with the overlap, if you will, between allergic rhinosinusitis and asthma, inhaled corticosteroids are the base of therapy. And they basically, as I put up here, the most effective in all steps. Most benefit occurs at low to medium doses, but you can go to high doses as well. And I got some treatment tables coming up in a few slides here that identify when would you consider kicking in from moderate to high dose corticosteroids. Now, your second agent is commonly going to be a choice between these leukotriene receptor agonists or the LABAs, the long-acting beta agonists. I've got examples up there, salmeterol, formoterol for the long-acting beta agonist, and montelukast or Singulair for the leukotriene receptor antagonist. But the point is that if the patient is not well controlled, let's say you've got them on a moderate dose of inhaled corticosteroid, they're compliant, doing everything they need to do, those are commonly going to be the choices you're going to make for your second agent. Now, when patients get more severe, up into the 5 and 6 stages of their asthma, you start thinking about some other therapies that, of course, pulmonologists would be the most experienced with in terms of applying, such as monoclonal antibodies that bind the IgE and keep it from actually causing the mast cell degranulation leading to the inflammation. It's interesting, methylxanthines, when I was a resident back in the 80s, again, it's talking about the 80s, we used theophylline all the time. And I'm just starting to see a little bit of a resurgence on this now. I just got off the hospital service at Michigan State, had a couple of patients coming in with severe types of symptoms that were still on methylxanthine. So there seems to be a little bit of a role for that now, but I'd say 30, 40 years ago they were really higher up on the treatment list, but kind of a niche therapy right now. Quick relief medications, the big one, of course, is going to be your SABAs, your short-acting beta agonists. Anticholinergics can act, as a short-acting quick relief medication as well. And of course, systemic corticosteroids are commonly needed to treat asthma exacerbations. They shouldn't be on the slide because they're not really quick relief medications, but just to recognize that systemic corticosteroids still have a role basically for managing exacerbations. Okay, so we've already made this comment about the use of beta agonists for more than 2 days per week is an indication that the patient's not doing well. We need to do something to add on to their therapy. So the following slides are a brief synopsis of the stepwise approach. And I think this is also a rule for everything in medicine. When you have a guideline, when you have a guidance, it really is meant to guide therapy but not replace clinical judgment, right? So it's everything in clinical guidelines. There's clinical judgment that comes in because not every guideline fits every single person's circumstances and the like. So I think it's a nice paradigm to think about when we're thinking about this idea of applying guidelines to the care of patients. All right, so this is directly out of the National Heart, Lung, and Blood Institute. You can see there's age-delimited, slight differences in age-delimited recommendations for stepping up care. So the first slide's 0 to 4, the second slide's going to be 5 to 11, and the last one will be adults, defined as greater than age of 12. So you can see there, step 1, intermittent. So I put the category at the top there. So the patient comes in, they have intermittent asthma, and you're only going to be using the SABA PRN. So they've met those criteria. They're using it basically less than twice per week, and their FEV1's greater than 80%, can still keep them on SABA. As they start moving into the persistent categories, one of those features that we talked about now tips them over to the persistent categories. Now you're going to start adding your controller medications. And you can see what I highlighted there in step 2, step 3, step 4, all the way up to step 6 is basically the base is inhaled corticosteroids. The only difference is this low dose, moderate dose, or high dose corticosteroids. And again, in your appendix, I've got a table in there that lists which are low, moderate, and high dose corticosteroids. And then, like I've already alluded to, you're making a choice on average between the long-acting beta agonists and the leukotriene receptor antagonists. So that's age 0 to 4. Almost exactly the same for 5 to 11. You have a few other choices in here. It's impossible, quite frankly, to memorize this table. I wouldn't expect you to do that. But I think for the biggest thing I want you to remember is the importance of the inhaled corticosteroids plus or minus the LABAs and the leukotriene antagonists. And this is the table essentially for age greater than 12. Okay, so what are some of the other elements we need to think about with regards to asthma care? How often do you see them? Well, it depends, right? It's like medicine. When you ever ask a question in medicine, the context always matters. So it's either 2 weeks up to 6 months, depending on the degree of control. So if the patient is still symptomatic and you've got them on treatment and they're not at risk of actually having a severe exacerbation, seeing them more frequently, obviously as they gain control less frequently, and working on stepping down therapy as appropriate. Education and self-management. So this is an important aspect. Much like diabetes, asthma is a lot of self-management and self-care and the like. So a lot of the locus of control switches a lot of ways from the doc to the patient. And I've got asthma action plans in your appendix, along with some other resources to help you with this particular element of that. So you would really want them to monitor their symptoms. Usually the peak flow is going to be the thing we're going to be using, but monitoring their degree of severity, either by peak flow or by symptom identification. They need to identify an asthma action plan, and as importantly, and fortunately YouTube now is full of great educational videos, how to use their inhaler appropriately, because if they're not gaining good control, the question you have to ask yourself, well, show me how you're using your inhaler, and if you're not sure how it should be used anyways, just go to YouTube and collectively sit down and with the patient and look at how the correct technique is. And of course, if you need to, you can always send them off to respiratory therapy for correct instruction. The other thing I put up here, I should have put this in red, is treating comorbid conditions. So there are other comorbid conditions listed up here that can lead to a lack of control of asthma. So you've got not only you're dealing with the issue of now you got inflammatory process going on in the lungs, you're dealing with that with your inhaled corticosteroids, but if you have untreated chronic sinusitis, that can lead to lack of control of symptoms. Of course, many of us aspirate at night, and we just clear it and basically goes away and doesn't cause us any problems. But recurrent nocturnal aspiration, GERD basically, can be a feature that's associated with a lack of control of asthma. And you've got some other features up there as well, some psychosocial features such as stress and depression. Are they actually using their medication appropriately and the like. Okay, managing exacerbations. People still die of asthma. There are some risk factors listed up there, so I've listed several of them up there. If they've had previously severe exacerbations, I mentioned, just got off the hospital service the last 2 weeks, had a patient in the hospital with a severe exacerbation. She was in the hospital for a week and had never really been appropriately instructed in the use of controlling medications. And, I never heard about that before, so it was hard for me to believe, but that's what she said. Multiple hospitalizations, obviously overuse of the short-acting beta agonists. Somebody who's mentally incapacitated to the point where they can't necessarily assess their own severity, psychiatric issues, and illicit drug use are all features that are risk factors for death. There's a simplified classification for severity here. You can see that up there, looking at just the peak expiratory flow. It's mild to moderate if the peak expiratory flow is 50% of the baseline. If it's less than or greater, if it's less than 50% or than the baseline, then you're going into the severe category. So in terms of managing exacerbations, the base for managing exacerbations is exactly the same. You're increasing the corticosteroid use, either inhaled or oral, and increasing the short-acting beta agonist use. And so for the most part, the really mild cases, the one that's listed up there, those features up there, can be managed at home with close follow-up. Almost every other stage, moderate, of course, severe, and life-threatening, of course, needs to be in the hospital. And you can see how those are defined up there. And again, what you're looking at here is increasing the frequency of the SABA use and the use of oral systemic steroids, and of course sometimes in the hospital with parenteral steroids as well. And with life-threatening, this is more ICU-based medicine, and these patients now are too dyspneic to even speak. These patients commonly are required to be in the ICU with adjunctive therapies listed up there applied to their treatment regimen. What about exercise-induced bronchospasm? Fairly common. This is basically a condition that is precipitated, of course, by exercise, and it can be easily diagnosed. Again, if you just get a peak expiratory flow meter and you're suspicious that the patient has exercise-induced asthma, have them do 2 or 3 puffs, average them out, or blows in the peak expiratory flow monitor, have them average them out, go off and do their usual exercise, and then post-exercise repeat that. And if there's a delta of about 10 to 15% decrease between pre and post, you've got your diagnosis. And the nice thing about this is it's relatively easy to treat. Short-acting beta agonists are wonderful. They're about 80% effective. You take a couple of puffs, about a half hour to an hour or so, maybe 2 to 3 hours or so before exercise, depending on when they're about ready to exercise, is highly effective. You got some of these other potential therapeutic options listed up here, but they're used much less frequently, only because of the fact that the onset of action takes quite a while. So if you get a question on the test that somebody coughs after exercising, they're not necessarily wheezing, think about exercise-induced asthma and not only the diagnostic criteria, but also how to treat it. Now, what about drug allergies? So there's 2 types of adverse drug reactions. There's the type A reaction, and that is predictable. For example, the examples I put up here are NSAIDs leading to gastropathy. That would be more of a type A. The other one is unpredictable. So you can never predict if you give somebody a drug whether they're going to have an allergy or not. It's just, at this point in time, not possible to predict that. And this is actually an immunological response and doesn't have necessarily anything to do with the pharmacology of that particular drug. Now, this is a busy slide here, but I'm going to try to break it down because drugs can cause 4 types of different allergic phenomenon. You're all aware that people can have anaphylaxis. Anaphylaxis is that type 1 reaction up there. And in this situation, there's an IgE sitting on a mast cell just waiting to be tickled, right? So that IgE is sitting there, and as soon as somebody takes in that drug, let's say penicillin as the antigen tickles, for lack of a better word, that IgE degranulates the mast cell, and within literally 30 to 60 minutes, you're having lots of symptoms. Now, the most severe symptom is going to be basically anaphylaxis. The most common form is going to be urticaria. So that's also an IgE-mediated type 1 reaction. So that's one way that drugs can lead to an allergy. The other one, which is, I'll talk a little bit this afternoon about heparin-induced thrombocytopenia. That is a type of class 2 immunological response, where the heparin actually coats, for lack of a better word, the platelet, and an IgG antibody comes in and affects that. So that's a second type. So heparin-induced thrombocytopenia is a type of a drug allergy, if you will. You can have drug and an antibody complex that's not fixed in the tissues, that's circulating around and leads to serum sickness, basically. And you can see some of the symptoms listed up. I didn't put them up there, actually, but rash, polyarthralgias, and fever. So if you got rash, polyarthralgias, and fever after drug exposure, that could be a type 3 reaction. And type 4 has nothing to do with antibodies. It's all about T cells. So you're all aware of the Stevens-Johnson syndrome, perhaps as a blistering skin disease when people get exposed to certain types of drugs and the like. That is basically a T cell phenomenon. So just a quick overview of the types of ways that drugs can actually whack the body from an immunological standpoint. Now, drug fever is probably a subset of type 3. Just know about this as a immunological response. The problem with this, of course, is that if a patient's on a drug, for example, an antibiotic, they have fever, you don't know if it's an ineffectively treated infection, in which case they need more drugs, or whether or not you're actually dealing with a drug allergy. This is sometimes really difficult to tease out. I would imagine that on a test, if you did get questioned on a test, it's going to be more of an outpatient type situation. And what I put up here is apparently allopurinol, which we use a lot, of course, for gout prophylaxis still, is one of those drugs that's implicated as causing a drug fever and the like. So if you get a question on the test where they're leading you down the pathway where patients got fever, but there are literally no signs and symptoms of infection, but they've been on allopurinol for a while, think about that as a cause of a drug fever. Now, anaphylaxis in adult, this is IgE mediated. Anaphylactoid, which I put up there, is basically the same symptom complex, but it's not IgE mediated. I'm not sure how important that is. But you can see the systems that are involved in anaphylaxis, which is basically leading to an exudation or a transudation of fluid into the tissues of the skin, the respiratory tract, the cardiovascular, the gastrointestinal system, all leading to symptoms that are associated with transudation of fluid into these tissues. So you've got hives, swelling, you've got basically difficulty breathing, you've got fluid leaving the cardiovascular system going into the interstitium, leading to hypotension and a lot of GI symptoms as well. Etiology is listed up there. And the big thing I want you to remember, of course, is that epinephrine is life-saving in this situation, and there are almost no contraindications to epinephrine. So you get a question on the test, somebody's coming in, you basically give them epinephrine. Now, all of the final 4 bullets on this slide are all about dosing, which I'm not going to get into. But the big picture here is epinephrine is life-saving in this particular situation. Now, in addition, after the epinephrine, of course, you're going to be giving them fluids to support their cardiovascular system. If they need oxygen, giving them oxygen, using bronchodilators in patients who are having some respiratory distress, and ultimately trying to reverse this process by using antihistamines and glucocorticoids as well. Big picture, though, anaphylaxis, think epinephrine. That's going to be the life-saving treatment for these patients. Okay, I've got just a few slides here on food allergies. Generally acquired in the first 1 to 2 years of life. Peak prevalence is about 8% or so, goes down to about 3% in adults. The point here is that kids outgrow some of their food allergies. Which ones don't they outgrow? And this is kind of an important concept. You'll probably, in some way, shape, form, or other might be tested on this. And it's really the fish and the nuts are not generally outgrown as children go from childhood into adolescence and into adult. So some of the other ones really are. You've got eggs and cow milk and wheat and soybeans. Typically children grow out of, but it's really the fish, perhaps more of the iodine-based fish, the sea fish, as well as the nuts that they don't outgrow. The guideline at the bottom is something you probably should know about also. This whole idea is how do we try to prevent peanut allergy? And the National Institute of Allergy and Infectious Disease it basically issued a guideline on this and saying that children before the age of 6 months should have a taste of peanuts, basically, or peanut butter or peanuts, to presumably then have an effect so that they're not going to ultimately develop an anaphylaxis type reaction to peanuts. So that's thought to be a helpful intervention to try to prevent peanut allergy in children. So just remember that as well. So there is allergy versus intolerance. I'm sure we have lots of patients coming in who say, I react to this food. And obviously it's true. The question is this a true allergy or is this just an intolerance? So there's some features up here that might help you think about whether there's just either intolerant to food or whether they have an allergy to food. So first of all, is there a clinical spectrum that involves some of the tissues that we already talked about? You got the urticaria there and the like. Is there symptoms that have their onset within 2 hours of ingestion? Do they have a repeated reaction from the same food over and over again? Are they in the high-risk food category, some of the ones that are on the previous slide there? Do they have symptoms as a child and have a history of other atopic-type diseases? Those all help you identify whether or not this may be a true allergy versus an intolerance. And of course, going on to testing, either diagnostic skin testing or serological testing is listed up there as well, can also help you make that diagnosis in the right clinical context. So what are some of the IgE-mediated food allergies, basically? Probably the most common one, I've seen this a couple times, my sister actually has this as well, which is the oral allergy syndrome, in which certain types of food pollens cross-react in the body, causing a local, almost like a local dermatitis, for lack of a better word, in the oral pharynx. And it doesn't, and it can be pretty scary because you can get a little swelling, a little itching, some tingling. It doesn't go down into the airways and the like. And this is probably one of the more common contact allergies that is basically localized to the mouth and throat. Again, associated with pruritus, irritation, a little bit of swelling, and it's generally brief. Now, the trick to this is that if somebody does have one of these, it's almost always brought on by eating raw fruits and vegetables. So just denaturing the pollen protein, basically, by cooking the vegetables, actually takes care of this as well. So it's a relatively easy fix. Atopic dermatitis, 35% of children who have atopic dermatitis will have a food allergy as a cause of this. And food allergies can also present as asthma as well. All right, so last slide here. Got some non-IGE mediated clinical diseases. So a couple I just wanted to point up here. The first one is the food protein-induced enterocolitis. This child is sick. They've got chronic vomiting. They've got diarrhea and failure to thrive. The trigger on this is basically a reaction to cow's milk, number one. Number two is the food protein-induced proctitis. These are children who present with bloody stools but look fine otherwise. And so this is thought to be basically a non-IgE mediated kind of an allergic type of disease to certain types of food. Celiac disease, obviously you got diarrhea and failure to thrive as the etiology of this gluten enteropathy. They're basically having a reaction to gluten. And finally, the last one listed up there is allergic eosinophilic esophagitis. And this is the child who's having recurrent vomiting and is not responsive to anti-reflux therapy, in which case you're starting to think about some of these other conditions associated with a problem of the esophagus, such as this as well. So they have feeding disorders, dysphagia, and vomiting. And I think that is it.